Dear colleagues, dear President of the Mexican Society of Gastroenterology, thank you for giving us this opportunity to present our practices about the prevention and the treatment of anastomotic leakage. To introduce this topic about anastomotic leakage, we can say that this complication is severe and also frequent. This is a severe complication because when it's happened, the patient will observe a higher risk of postoperative mortality. He will spend more time in hospitals, and also he will observe a worst functional result of the anastomosis when he will go back home. Finally, that's the quality of life for the patient that will be impacted by this complication. Due to these bad functional results, or also due to the acute complication of the anastomotic leakage, many patients will have a definitive stoma. Recent study has suspected also an alteration of the oncological prognosis, as this complication may alterate the immune function for the patient and increase the risk of proliferation for tumoral cells. Regarding the frequency of this complication, it's found to be compromised between 3 to 25%. In our experience, this complication occurs around 15% of cases. For a long time, many definitions of an anastomotic leakage exist. So it was difficult to define what is an anastomotic leakage and to compare this outcome between the studies. Thanks to this publication in surgery, we have now an international definition of the anastomotic leakage, and we have to use it to define an anastomotic leakage in our studies. In this table, you can see the definition of an anastomotic leakage, which is a defect of the intestinal wall integrity at the colorectal or coloanal anastomotic site, including suture or stable lines of neorectal reservoirs, leading to a communication between the intra and the extraluminal compartments. It's important to see that in this definition, they have also precised that a pelvic abscess close to the anastomosis is also considered as an anastomotic leakage. Probably in the publications with a very low rate of anastomotic leakage, such as 1 or 3%, it's likely that the authors did not consider pelvic abscess as an anastomotic leakage. Additionally to this definition, they are proposing a severity grading of the anastomotic leakage. Grade A, when this complication does not require any active therapeutic intervention. Grade B, when this complication needs an active therapeutic, but without surgery, without re-laparotomy. And grade C, when the patient needs to be brought to the operating room for laparotomy. In this table, you can read all the clinical characteristics of patients with different severity grades of anastomotic leakage. Regarding the frequency and the severity of this surgical complication, the first point that we will explore here is how to prevent the occurrence of this complication, and so how to detect them and to fight against the risk factors. As you can see here, you have a risk factor before the surgery, during the surgery, and after the surgery. The Dutch Colorectal Audit Group has made some research to find all the risk factors to prevent this complication. Regarding the non-modifiable risk factors, some of them relies on the patients directly, such as the age, the sex. The male observes a higher risk of this complication compared to females. The BMI, and also all the comorbidities such as the diabetes and the kidney insufficiencies. Other non-modifiable risk factors relies on the disease directly, such as metastatic disease, an important tumor locally that invade adjacent structures, and the localization of the tumor on the rectum, because we know that when the tumor is close to the anus, the postoperative risk is increased. And then the important part of this prevention relies on the modifiable risk factor that can include the smoking, alcohol consumption, the medical treatment such as the steroids or the immunosuppressive treatment. Another major point is the pelvic radiotherapy that is well known for being an important risk factor of anastomotic leakage. In that point, it's very important for the surgeon to be involved in the discussion during the MDT to define the importance or not to propose this neoadjuvant treatment, as the postoperative course will be influenced by this treatment. And finally, we know that the experience of the surgeon, his age, and also maybe his sex, as a recent study found that female may have a lower rate of complication than male. And the final point is the surgical experience of the hospital, and maybe a cutoff of operation might be installed in each centers, as below a certain cutoff there is a significant increased risk of anastomotic leakage. How can we prevent the anastomotic leakage occurrence after surgery? Current studies are assessing the importance of antibiotics before the surgery. Another point was the immunonutrition. We know that now this treatment is maybe not very efficient, and in our center we don't propose immunonutrition before surgery anymore. But probably the more important point is the physical preparation before the surgery, including physical activity and improving the nutritional status for the patient. To prepare a patient for colorectal or coloanal anastomosis, should we propose a bowel preparation before the surgery? There is one trial done by a French group called GRECA. This study called GRECA-3 has compared one group of patients without bowel preparation before TME compared to another one with bowel preparation. And in this study, they have found that doing this bowel preparation reduces significantly the postoperative morbidity and the infectious complication. In this study, the anastomotic leakage rate was of 19% in the group without bowel preparation, compared to 10% in the group with bowel preparation. It was not significant regarding the p-value, but the importance is quite important. And we know from other studies that this preparation can reduce the occurrence of anastomotic leakage. When we look at the other surgical characteristics, first of all, the surgical approach. Up to now, there is no real difference between laparotomy, laparoscopy, and a robotic approach regarding the risk of anastomotic leakage. The TIA-TME also has been assessed, and it's unsure today if this approach might be helpful or not in this context. The technique of the anastomosis, ensuing anastomosis compared to stapled anastomosis. Here again, there is no serious data to prefer one of them. The only point that we know is the stapling of the rectal stump. When we do more than 2 stapling, there is an increased risk of anastomotic leakage. So during the surgical preparation of the rectal stump, we have to consider that point and trying to reduce the number of stapling applied. Finally, the reconstruction of the anastomosis. Should we do a direct coloanal anastomosis, or should we prefer the confection of a reservoir, such a G pouch? recent study have found that the functional results is similar between a direct anastomosis compared to anastomosis with a reservoir. And when a complication occurs, it's easier to manage with a direct anastomosis. For this reason, in our center, we prefer to perform direct anastomosis whenever it's possible. We know that an important point to limitate the anastomotic leakage is to reduce the tension on the anastomosis. Thus, there is some possibilities during the surgery to be proposed by the surgeon to fight against this tension. The first one is the mobilization of the splenic flexures. We know that some surgeon doesn't do that systematically, but propose this mobilization only in case of tension on the anastomosis. In our hospital, we try to perform this mobilization for all TME in order to be certain to obtain tension-free anastomosis. The second point is the vascularization of the bowel, and there is this question between low ligation or high ligation of the superior mesenteric artery. Should we preserve the superior left colic artery? Here again, there is no solid data in the literature to know if it's important or not. In our point of view, we always perform a section of the superior mesenteric artery at its origin without preserving the superior left colic artery, as we believe that it reduces the tension without altering the vascularization of the bowel. Additionally, during the surgery, a green test with endocyanin can be performed to ensure the good vascularization of the mobilized colon. We have finished now to consider the preoperative factors, and when we look now at the intraoperative factors, it's difficult to define which is the cause and which is the consequence of the anastomotic leakage, but it's known from the literature that long surgery with an operative time longer than usual, the important blood loss during the surgery, the resection of other structure close to the rectum, and also conversion from laparoscopy to laparotomy are factors of complications. At the end of the TME and after the anastomosis, the surgeon can decide or not to place a pelvic drain close to the anastomosis. A randomized controlled trial has been proposed by the French group of research called RICA 5, and in this randomized study, no benefits of the drain has been identified, and the risk of anastomotic leakage, also the severity of the anastomotic leakage, was similar with or without drain. So the conclusion of this study is the use of a pelvic drain after rectal oxygen for rectal cancer did not confer any benefit for the patient. After that, should we perform a diverting stoma after a low colorectal anastomosis or coloanal anastomosis? You have this interesting study published in colorectal disease from the Italian Society of Surgical Oncology that have found in a very large population that the rate of anastomotic leakage was not influenced by the confection or not of a diverting stoma, but the severity and the risk of surgery on emergency is reduced when the stoma is performed. In another study on the same topic, they find in this prospective randomized trial that performing systematically a diverting stoma reduced the severity of the fistula and also reduced the occurrence of the fistula, contesting the conclusion of the previous study. In this trial, they found fistula rate of 6% when a stoma was performed compared to 16% among patients without diverting stoma. So we can see that the leakage rates and the reoperation rates for leakage were significantly higher in patients without a stoma. Regarding this conclusion, we always propose a diverting stoma for patients after a low colorectal anastomosis or a coloanal anastomosis. Despite the importance of the diverting stoma to reduce the severity and the occurrence of anastomotic leakage, we know that this kind of stoma can be difficult for the patient from a psychological point of view. There is also an important morbidity related to this kind of stoma. And finally, there are some concerns about the functional consequences of diverting stoma on the digestive function after the closure of this stoma. So this is why the French group of research on the rectum, the GRECA group, is proposing a study, a randomized controlled trial that is ongoing to evaluate a strategy of avoiding stoma among selected patients. The first step in this study is to calculate the modified anastomotic leakage observed risk for the patient, and you have here 5 criteria: the gender, the body mass index, smoking, diabetes, and tumor size after the neoadjuvant treatment. And with these criteria, you can obtain the risk of anastomotic leakage for the patient before the surgery. In this study, the patient will be randomized either in the control group, so they will have in this group a diverting stoma, and this stoma will be closed 3 months later as a standard care, or they will be randomized in the experimental group, and the intervention will depend on which score of anastomotic leakage they will have. If there is a low risk of anastomotic leakage, so a score of 0 or 1, so they will have this anastomosis without stoma. But for patients with a high risk of anastomotic leakage, a score of 2 or more, they will have a temporary stoma, and then postoperatively they will be assessed early with a CT scan, and if there is no fever postoperatively, no leak on the CT scan, and day 2 CRP below 115, there will be proposed an early closure of the stoma between day 8 and day 12. So as you can see, the aim of this study is to reduce the confection of diverting stoma and to adjust this strategy on the risk for the patient. So this is an ongoing study. We'll have the results in a few years, and until the result of this study, the gold standard is to propose systematically a diverting stoma after TME and coloanal anastomosis. Other tricks has been assessed intraoperatively with this aim of reducing the anastomotic leakage, such as intraoperative endoscopy, such as transanal drain, jacuzzi test, blue test, but none of these associated measures, not all of them are written here because many of them has been tried, but none of them was really important or significant to reduce these complications. So up to now, we are not able to recommend one of them during the surgery. As far as we know, there is no prophylactic measure to propose postoperatively to avoid an anastomotic leakage. So the only thing that we can do postoperatively is to assess every day the patient and to be able to diagnose as soon as possible an anastomotic leakage when this complication appears, to propose an early treatment which is known to improve the outcomes when this complication is detected. Many studies has focused on the blood test to assess the occurrence of this complication, or the CT scan, but what I would like to say here is that the clinical examination of the patient every day or twice a day is also very, very important, and an anastomotic leakage is most of the time detected firstly by clinical signs, so fever, unusual abdominal pain, small bowel obstruction, confusion, postoperative confusion, the aspect of the liquid in the drains. All of these signs might be followed and should be followed by the surgeon to detect an early anastomotic leakage. The performance of the CRP to detect an anastomotic leakage before any clinical sign has been largely evaluated in the literature, and so the precise cutoff is not well known, and as each study reported his own results. But what we know is that the CRP is an important blood test after colorectal surgery, and indeed it can be increased when an anastomotic leakage occurs before the appearance of fever or other clinical signs. More than just the value of the CRP, the other important element is the evolution of this blood test over the time. Here you can see on the figure that the highest rate of CRP is reached at day 3, and when there is an anastomotic leakage, then it's going down, but increasing. But it's increasing after that, and when there is no complication, it's going down after day 2, and and it stays low after that. When we suspect an anastomotic leakage, we will propose an abdominal, pelvic abdominal CT scan with IV injection, and possibly also with bowel opacification. The main problem of this exam is that its performance is not excellent, and the sensibility and the specificity is not of 100, and we know that the risk is of wrong negative tests, with patient observing a normal CT scan despite the presence of an anastomotic leakage. So we have to be very vigilant when a patient observes a clinical sign of anastomotic leakage without any signs on the CT scan. The other option to try to diagnose an anastomotic leakage is the rectal examination that can be done at the bed of the patient, but due to the pain after the surgery, it can be a little bit difficult to do that. So when we want to explore the anastomosis, we believe that it's most of the time better to do it in the operating room under general anesthesia. And here we can do a very good rectal examination, maybe a small endoscopy to look at the anastomosis, and also if there is an anastomosis, we can treat it in the same time, such as evacuating the pus and insert a drain, for example. The second point of this presentation is how to treat an anastomotic leakage. The aim of the treatment is to reduce the mortality and also to improve the functional outcomes for the patient without the definitive stoma after this complication. We know that during the treatment of an anastomotic leakage, an important point is to try to preserve the anastomosis as much as possible, as we know that to take down the anastomosis during an emergency surgery is sometimes needed, but when it's done, the risk of definitive stoma is very, very high because in the pelvis, the small bowel will go there and the fibrosis will occur there, and then to redo the surgery to perform a new colonal anastomosis will be extremely risky and difficult. So whenever it's possible, we have to try to preserve the anastomosis with the fistula. The first point to be assessed when there is an anastomotic leakage is the delay between this diagnosis and the surgery. When this delay is very short, shorter than 2 or 3 days, most of the time is due to an ischemia of the mobilized colon. So it's in this specific case important to go back to theater on emergency to assess the vascularization of the colon. As you can see here on the picture, there is a necrosis of the mobilized colon. So this situation has to be suspected when there is a fistula during the first 2 days after the surgery. And in this situation, what the surgeon should do is to resect, of course, the necrosed colon, and if it's possible, to redo a coloanal anastomosis. An alternative is to perform a delayed coloanal anastomosis when it's possible, as it will delay the anastomosis and maybe it will reduce the occurrence of a new anastomotic leakage. When it's not possible, the anastomosis will be taken down and colostoma will be done. As we said previously, in this situation, the risk of definitive stoma is very high. When we face a patient with an anastomotic leakage, we have to determine the severity of this complication, as the treatment will be influenced by this element. 1 out of 4 patients will not have any symptoms of this complication, so this is the lower severity, and at the opposite, 1 patient out of 4 will be with a peritonitis, so representing surgical emergency. When the patient presents some clinical sign of severity, it's important to go back to theater on emergency, and the surgery should be performed through a laparotomy, because minimally-invasive approach will not be appropriated regarding to the severity of the complication. If there is a necrosis of the colon with a patient presenting an hemodynamic instability, the anastomosis is taken down and the terminal colostoma is performed. Otherwise, if the patient, if there is no necrosis of the colon, we can propose just a drainage close to the anastomosis. A diverting stoma have to be performed if it was not done before, and it's important to wash all the colon with water if a diverting stoma is performed, to avoid all the stool in the colon that will go through the anastomotic leakage. At the opposite, when the patient doesn't have any severe sign, no sign of peritonitis, no sign of hemodynamic instability, we will try to avoid the surgery, and we will try to preserve the anastomosis during the acute phase of the treatment. So first of all, the antibiotics will be extremely important, and also nutritional support will be important to help the patient to fight against these important infections. And then we will propose some local treatments that we will have to decide between an endoscopy, radiological drainage, a surgical drainage, or an endosponge, so a treatment with negative pressure. Several treatments through an endoscopic approach have been tried, such as a stent or the insertion of drain, like pigtail drains, also metallic clip, but we know that the performance of this endoscopic treatment is really limited, and usually we do not propose this kind of treatment in our hospital. For patients with an abscess around the anastomosis and without any peritonitis or diffuse infection of the abdomen, the good approach associated with the antibiotics is to drain this collection in radiology. So the radiological drainage was often performed in our hospital, as you can see in this study. It was concerning 70% of the patients who observed an anastomotic leakage, so it's an important part of the treatment, and and the drainage was mainly performed through a radiological approach. What we have found is that half of the patient did not need additional intervention after this drainage, and finally, at the end, 80% of the patients who presented an anastomotic leakage did not have a stoma, so the bowel continuity was definitively preserved for the long term. The alternative of the radiological drainage is the surgical drainage through a transanal approach of the abscess. So the patient needs to be in the operating theater under general anesthesia. And as you can see here on the pictures, we can insert a drain through the fistula. And thanks to that, we can irrigate and wash the abscess post-operatively. The advantages of this treatment is that it's easy to perform, it's not really expensive, it's only one surgical procedure, so it's very easy to propose and to manage. An alternative to this transanal drainage, which is pretty new, is the endosponge. So it's negative pressure therapy, and the device is inserted through the fistula. In the abscess, as you can see here on the pictures, and the patient will left the theater with this through the anus under negative pressure to evacuate all the dirty content in the abscess. The positive part of this treatment is that maybe it can help the local healing with the granulation of the tissue. At the opposite, it's an expensive treatment. The patient is brought to the operating room every 2 or 3 days to change this device, and we don't know exactly how long should we leave this device through the fistula to obtain the best results. In this study, they have collected more than 170 patients who were treated by this endosponge. And they found that the number of operating procedures was 11, so each patient was brought approximately 11 times in the operating room to change the device. We can see here one of the limits of this treatment. So the duration of this treatment, the median duration of the treatment was 34 days, but the results were excellent as the complete healing was reached for 94% of the patient, and for the long term, 75% of the patient did not have any stoma. In another study done in France, in 8 centers, including 62 patients, we saw that the number of changing procedure was inferior to the number found in the previous study. It was 6.6 procedures to do that. The median duration of the treatment was 27 days, and 81% of the patient has a diverting stoma additionally to this endosponge. To conclude, we can say that the anastomotic leakage is an eternal problem for the colorectal surgeon. We have to improve our knowledge about the prevention, the diagnosis, and the treatment of this complication. We can say that it's very important to diagnose very early this complication, because the treatment will be better compared to a delayed diagnosis of the complication. And we have to preserve the anastomosis whenever it's possible to reduce the risk of definitive stoma. Thank you very much for your attention.